Well, the war against moderate to severe calcium is an ongoing battle we fight every day. It's a common problem in the patients we treat, and the more complex the lesion, the more calcium tends to be present, especially in patients with advanced diabetes and renal failure. Are we winning the war? Depends on how you define that. I think we have to talk about the acute battle and the long-term success in the war. The acute battle is often waged, given, to extend your analogy, often waged with things like atherectomy. Atherectomy can be effective in certain types of calcium and certain types of atherectomy devices. They typically involve the risk of perforation, the risk of embolization, the latter of which would require filter deployment, increasing the cost and complexity of the cases. Other ways that calcium are managed are with straight up stenting, like with the superior stent, with very aggressive predilation and vessel preparation, and that has been shown to be reasonably effective as well. But again, lots of manipulation of the vessel with potential complications. So in the acute setting, yes, we have some tools to take against calcium, but it's, I would say, incomplete and frankly, never been fully tested in a randomized trial. So let me just say that up front. We do have these tools, but we extrapolate a lot of the use of those tools from non-randomized trials in potentially not extremely calcified lesions. The second component of this is the long-term outcome of the battle. And I would say that if you look at the drug-coated balloon data sets, where drug-coated balloons in severely calcified lesions appear to be less effective in maintaining patency over the 1 to 2 year time period. And that, I think, is a battle we're losing and potentially could use some reinforcements, again, to extend your analogy. In the acute setting, I think the PAD3 data set is actually quite important and informative. It's the first trial that actually took patients with moderate to severe calcification and included them rather than excluded them. In most pivotal trials, exclude these patients primarily because they tend to be difficult to treat. They require adjunctive treatments, like I just talked about, with either atherectomy or stenting, and mixing the treatments tends to confound the outcomes of a specific analysis of a device. So they tend to be excluded from many trials. This trial actually included them purposefully because the goal and purpose of the device, which is built to treat calcium, is to see whether, as an adjunctive tool, an enabling tool to establish patency at the beginning, whether it was effective in doing that. So the trial randomized about 150 patients in each arm to either straight up PTA, old-fashioned balloon angioplasty, versus IVL, which is intravascular lithotripsy, and randomize them. And the primary outcome is, as you mentioned, the acute result. So after both treatments, angiographic core lab analysis and site analysis was done to establish whether or not a less than 30% residual stenosis was achieved without the use of a stent and without a type D or worse dissection. And when you look at those results, you actually see that lithotripsy had roughly a third of third to a quarter of the need for stenting or a severe dissection, and achieved a better lumina outcome with just lithotripsy before any adjunctive therapy. And so we see that as a primary tool to treat calcified lesions, it's better than PTA in every measure. Not surprising, because PTA, as I mentioned earlier, is really not a great tool for heavily calcified lesions. So its primary outcome has, I think, satisfied both the efficacy of being better than PTA, but also showed that it was as safe as PTA with very, very low rates, mostly zero rates of complication, embolization, perforation, dissection, and so on. So the acute primary outcome has been in favor of IVL over PTA. We will have a secondary analysis because all patients then were treated with DCB, plus minus stenting as needed. And the DCB outcomes at 1 year are being tallied. And once those data are available, we'll present those. They're powered secondary analyses for patency. And that will be very important because, as I mentioned before, the long-term goal is to try to get not only the acute results secured, but also long-term patency assured. When faced with calcified lesions, they now have randomized level 1 evidence that the intravascular lithotripsy is effective and safe in reducing the stenosis that they're looking at, whether it's a CTO or a highly stenosed lesion, without the need in 90% of patients for adjunctive therapy. And so they will have a choice now, in addition to stent implantation with Supera or atherectomy with filter embolic protection, to use IVL as a potentially more expedient, frankly, way of doing this work with a more predictable outcome as relates to dissection and stenosis relief.